Welcome back, everyone, to another episode of Grow Your Path to Wellness. Last episode, a couple weeks ago, we hosted a friend of mine and a fellow wellness professional, Kendra Everhart. Kendra shared with us the importance and benefits of movement, dance, and how she kind of created her own kind of approach and calls it vibology. So the benefits holistically of just for one's wellness whenever it comes to incorporating yoga, movement, and dance, and how this also improves self-esteem and self-worth. And then this week, we welcome, I think, a fellow TikToker. I don't know if Chelsey and I have kind of crossed paths, but I know that comes up often on our recordings with new guests. But also, so she lives in Ohio with her spouse and two sons. She's a licensed independent social worker with a supervisor credential and specializes in treating trauma and anxiety with modalities like acceptance and commitment therapy and dialectical behavioral therapy. So welcome, Chelsey. This is Chelsey Hams. Thank you so much for being with us today.
Thank you. Thanks for having me.
All right, Chelsey. Yes, Chelsey's a fellow TikToker. So we are always happy to have those mental health TikTok professionals here sharing all the good information. Chelsey, tell us a little bit about you, your background, your training, and why this topic today.
So I, right after high school, I got an undergrad in psychology, and then I worked on an inpatient unit for about 10 years. And then got my master's and started working in therapy. And I think just through the course of treatment and trainings, I found that I very much prefer working with anxiety and treating anxiety. And then more trainings found working with trauma to be kind of a passion of mine and learning more about it. I'm always learning. I'm always going to more trainings just to kind of get the best options. I'm kind of like a trauma nerd at this point, is if I see it, I'm like, let me learn about it. I don't really know why personally I'm drawn to that. I think I've just developed a good understanding and ability to handle what I hear and then help people through it.
Yeah, I was just going to say I had a similar path. Well, I did my undergrad and master's back to back, but my undergrad was in psych, and then I did social work. And the same thing, like anxiety started to just kind of call to me. I was like, well, yeah, like this is quote unquote normal, right? Like this is like a normal biological response in your body. Like, okay, let me help you hone that in and train it so that, it's usable for you. And then trauma, right? Like we all have some of some kind, and it's usually having secondary impacts on our lives and symptoms. So I appreciate that and your perspective.
Yeah.
Chelsey, I was going to ask you, do you work with both adults and children? And what area of Ohio are you in? Since all three of us and our guests are in Ohio, often we're all over the
Yeah, so I'm in Toledo. I work in like a tiny little town outside of Toledo. But I currently primarily just work with adults. I was working with children for a while. That was actually my first job out of grad school, was doing a group, like a more intensive group for teens. And I do love working with teens. I found I had to take a step back from that because it became difficult with the situations in that I couldn't help enough because of the guardians, and it became too personally frustrating for me. So I had to take a step back and just focus on adults for my own well-being because it became a little upsetting. So
yeah, I see you in that, because long story short, I'm like way down southeastern Ohio, like the Hocking Hills, if you've ever been down hiking. So like that's where I'm at. And I come from a lot of community mental health. I've never done inpatient, but the whole, when I went out on my own, I still work with teens, but I keep it a very small portion of my caseload for similar reasons. So
yeah, I had a few really difficult cases that the kids and I were doing really well together, and then the guardians don't like certain changes that come about or don't like facing certain things. So they pull them out of therapy. So it's just became too frustrating for me.
Yes. Yeah, no, I hear you 100% in that.
Yeah.
And it can be very, we have to acknowledge that for ourselves and in the
Yeah.
field. It's more about the client or, you know, or that person. It's doing something for us and it's not making it us beneficial for that client. So, but no, thank you for sharing that. I was just curious.
Yeah. So now I'm primarily adults. I have all age ranges. I have like, 20-year-olds. I have a few still like 18-year-olds. I have 70-year-olds, like the whole range. So
Nice. Okay. So maybe we can jump in and just start with all three of us being clinicians, we kind of just know these things. But for our community who listens, can you maybe share some details about those two diagnoses like separately? So some common symptoms of trauma, anxiety, and maybe flesh out a little bit for some how those overlap.
hmm yeah, I think anxiety tends to be a lot of body experiences, muscle tension, stomach issues, nausea, some maybe like panic attack symptoms of the heart racing, the hot flashes, but then also the anxiety in terms of the excessive worry thoughts. And then it can be broken down to types, right? Where it's like worrying about everything, worrying about a specific phobia, worrying about social situations. But the common theme, I think, is the excessive worry that you cannot control, and that makes you tend to avoid the things that make you anxious, which then seems like it's helping, but it's actually exacerbating the anxiety. And then differentiating that from trauma, I think trauma does come with a lot of anxiety, but for a different reason, with specific traumatic events that have happened, with maybe like nightmares, flashbacks, memories. And then I think it tends to also more involve specific cognitive differences in terms of a lot of self-blame or self-worth issues or excessive cognitive beliefs about the world around you being too dangerous, and a lot more hypervigilance, being excessively aware of what's going on. I think the trauma symptoms definitely mimic anxiety, but for more specific reasons and more intensity in symptomology and responses. Trauma is just very complicated, as you know.
That's such a good way of like you handled that so well of describing those differences and the overlaps. And then I think also, I was thinking before you said the thought patterns about and beliefs about the world, I was thinking, complex PTSD where there might not be specific flashbacks to specific events or situations, but it was more developmental trauma or, the relationships that we had with our caregivers and how that shaped our view of the world.
Yeah, it's very, I think, differential per person and how they respond, and definitely the, the diagnostic part of it, the barriers of the DSM criteria, where, they have to meet like the most criteria of any diagnosis, but, it doesn't always look the same in every person. Some people don't have the nightmares or flashbacks, but they have these super intense hypervigilance and anxiety and everything else. But it's trauma, especially if they don't have the memories of it, because that's also part of trauma. The missing of, the memory lapses make it so they don't have flashbacks because they don't remember it, but they still have trauma.
The power of association.
Right.
It's so challenging too, because their body remembers it. Somewhere in them remembers it, right? It's just that we can't bring it to that present awareness. We can't consciously recall it. Yeah. And I know that's a big challenge for a lot of people I've worked with, is like, well, I don't know, I think this might have happened, or I think something happened, but if it didn't happen, then it probably didn't happen. I don't know, did it? Right. And they kind of waver. And I've just, learned to tell them it doesn't really matter, honestly, like in the kindest way. I'm not like, but
Right.
basically it doesn't matter. if you can recall
Yeah.
or not, you know, if it feels true to you, if it feels like it's impacting you in some way, let's work with it.
Mm-hmm. Yeah.
So, okay, thank you. Can you talk on, a lot of people throw around these, not analogies, what's the word? Acronyms, right? Like CBT and DBT and ACT and all the things. And in our community, we know what that means. But again, for our listeners that might not be so trained, we mentioned acceptance and commitment therapy and dialectical behavioral therapy that you are trained in and use. Can you kind of flesh those out and help our listeners understand what that might look like if they found an ACT or DBT therapist, what issues, you know, the anxiety, depression, trauma that can help treat?
Yeah. So I first learned about acceptance and commitment therapy in grad school. My field advisor had been trained in it, so she really trained us. My grad school was a very CBT, as most of them are, focused grad school. But then she added that in, and I tend to use ACT for a lot more for anxiety, you know, because like CBT talks about, you know, making an alternate thought, you know, to combat your intrusive thoughts. But what I found is that people then get in the argument back and forth of alternate thought, intrusive thought, alternate, and it ramps up the anxiety. So ACT talks about mindfulness. It talks about focusing on your values. It talks about treating your mind as a separate entity, like a separate person, to recognize it's not you and you don't have to actually follow this. So there's the skill of diffusion. That's one of my favorite skills for anxiety, because it's talking about getting out of that internal argument and focusing more on, are these thoughts helpful? Are these thoughts necessary? Mindfulness tools of like imagery, where you imagine the thoughts, say, being written in sand and then the waves wash them away. Ways to disconnect from those thoughts, to recognize they don't need to have power over you. I found that to be a much more helpful tool for anxiety thoughts, just because it gets rid of that perpetuated argument and recognizing the thoughts are not absolute truth. And then, so I use that a lot for anxiety. And it can be useful for depression too, with the same intrusive thought patterns. The dialectical behavioral therapy, I think, is a much more, in my opinion, it's useful for everybody. I mean, I use the skills myself for certain situations, because there's a skill. I always tell people, if you give me a problem, I have a DBT skill for you, because it's just so in depth of a therapy. If you're doing true traditional DBT, it's very intensive, where you do a group and then you have an individual session, and the individual sessions are very structured, like diary cards, a structure of what we're covering. I don't tend to do that. I was trained that way. I did a year-long training for DBT. And I did a group with teens, a DBT group, for a couple of years at my previous job. So I tend to use DBT when it's needed. You know, if I just had somebody the other day that was going through a breakup, so we covered opposite action of love. There's emotion regulation skills, just a full gambit of things, depending on what the person needs in that moment. It obviously was created for borderline personality, but I think over time it's been known to be beneficial for most things. I don't necessarily use that for trauma, just because we have other things to work on for that. But DBT, I do tend to kind of like use it throughout, depending on what the person needs in that moment.
It's great for like peace work. And I love that the interpersonal piece of it. Like I work a good bit with BPD, humans that live with BPD, and I love I incorporate that in amongst some other things, but I like the integration or the incorporation of the relationship piece with DBT versus some of the others where it's very much internal, or which are great, but I like turning to that for that that piece as well.
Right. And there's so many different options to use depending on what the person has going on. I do use a lot of distress tolerance for people with anxiety. And then the mindfulness is obviously useful for everyone. So yeah, it just kind of depends on what that person needs in that time. So I'm not a structured DBT therapist. I've done that a couple of times, and that's just not my flow in therapy. I tend to just want to go with the flow, what we need to do that day, not be like, we have to do A, B, and C. So that's why I'm not certified in it, because you have to do that to be certified. So yeah, I use it how we need to.
Yeah, I heard you say you don't necessarily use it like for trauma. Do you take like a piecework approach usually for trauma as well, or do you have your go-tos for trauma specifically whenever it feels kind of, it's hard to make this so black and white when it's in reality not, but do you have some favorites or go-tos for trauma treatment?
For trauma treatment, I tend to be more of a polyvagal theory practitioner of, we have to kind of start with the body. We have to start helping you, use coping skills in the moment. I did there's a training by Eric Gentry for the trauma professional. So I tend to follow his structure, the relational pyramid of just developing the rapport with the therapist. Because as we know, that's actually the most important part of treating trauma, is giving them a healthy relationship. And then the coping skills and like the cognitive restructuring aspect. So for that, I sometimes will use some diffusion or CBT, depending on what works best with that person. I usually will start with CBT options, at least helping them label the cognitive distortion in the moment. And then if we find there's an internal argument happening, then I just switch to diffusion, given whatever they need in that moment. And sometimes I will ask them, do you tend to internally argue with yourself? And if they say yes, I don't even do CBT, because it's just not going to be helpful. So.
And then I like to ask everybody, as far as like, because we're all three, I've seen your credentials, we're all social workers by nature. And
yeah,
and I feel like it comes up in almost every conversation, but are there other things that you take in consideration about a person, or some maybe aspects of your intake, or not just tied to the specific diagnosis, but as you're fleshing out what modality do we feel like is helpful, what other things can somebody expect to be asked about? Like if they're coming to you with anxiety, trauma, one or both, kind of other aspects of the human that you ask about or take into consideration?
I tend to always assess to their current environment, because let's say they're still living with the traumatic situation. We are very limited in what we can do. We can still do things, but then we have to kind of develop more options for that person in the moment, because if they have no support system, if they have, difficulty working, they need help getting disability, they are living with maybe an abusive person, we have to kind of assess the whole picture of it. Because as we say, you can't fully heal from the trauma while you're in the trauma. So then we have to kind of figure out, okay, what can we do to get you through this until you can actually be out of it, survival skills. Because I will explain to people how your nervous system works and why we can't actually fully work on this right now, because you need your nervous system to protect you. So those are, I think, the biggest things I assess, is if they have a support system, if they have resources in terms of, access to medications, or access to outside hobbies, or, just all the different things that they could do outside on their own. And then also the safety of the environment.
Yeah. And I asked that not to put you on the spot, but I like that, because when we get in here and you start talking about these like we said, the acronyms and the modalities and the approaches. And I feel like people get a misconception. Like when they come in, it's like, all right, that's going to be the only things that we talk about. And it is super structured. And sometimes people aren't there yet. Like there's so many other things we have to get in place before your mind and body and all of these things line up to where you can learn and apply these skills into your day-to-day life. And we always tell our clients, Amanda and I, like, you're the expert in your own mind and body. And sometimes it's most of the time, you're not going to just jump in right into the structure. There's going to be some follow-up or some lead-in kind of evaluation and determination first.
Right. And I think a lot of people too even need, I think that's the basis of trauma treatment as well, as just education. I often spend time with people explaining that they even experienced trauma, that experience wasn't just like, quote, normal. I don't like that word, but you know what I mean? They think everybody has this. And I've had this happens a lot where people don't even recognize oh, it was fine. It was great. It was fine. Was it? So having that conversation and education, sometimes that alone can actually help the person do more for themselves once they recognize, because it's kind of like Pandora's box. Once you learn it, you can't unlearn it. And then you see it in your life. And that alone can be regulating for the person to know what changes they need to make. I had one girl in particular, I think she was 18. She'd been diagnosed with bipolar disorder at like age 8. And I did my assessment, knowing in my mind, like, that's not what this is. And then we found like the household she was in was severely traumatizing, mental health issues in her own parents and all of this. And it took about like 4 or 5 sessions for her to recognize what was really going on. And she made a plan for herself to move out with a grandparent. She moved out and she like completely healed herself just being in a safe environment alone. She was like, actually, I'm fine now. And she just moved on. But it took a while. That was our therapy, was helping her understand this was not a bipolar situation. This was a trauma situation. This was not your fault. You don't have to actually live this way. And yeah, she just did the steps for herself and got through it.
Yeah, like, of course you're dysregulated. Of
Yeah.
course you have intense emotions that you don't know how to manage. Like, of course. I always tell people, like, whether I do a lot of clinical supervision, so whether it's when I'm, training them or just in general, people ask, like, what is your therapeutic approach? What theories, what theoretical orientation? And I'm over here like, listen, psychoeducation and validation are like the 2 biggest things I do. And just the weight that is lifted off people, or the light bulbs you see, just giving someone information, like, you don't know what you don't know, right? And once they have that, they're like, what? That's a thing, or like, wow, right? And it's empowering. And I think as social workers, that's a lot of our job too, right? Is to empower our folks to do what they need to do for themselves with the information that they needed to do it.
Right. That girl in particular, but this happens a lot when I tell people, you're not responsible for their emotions. Her jaw like dropped because she had been taught she had to take care of them. She had to do what they needed. And you were a child. That wasn't your job. She sat in silence for a minute after that because it was very foreign for her to be told that. And I think that piece of information for a lot of people alone is very shocking. And then once they can accept that, it can make huge life changes for themselves.
Yeah, it's so powerful. Well, Chelsey, we just flew right through all of that. I don't know how we already got to them, but here we are. Thank you so much for joining us. Are there any parting words, any last minute things you want to leave on this topic, or any mantras or quotes you want to leave with our guests or our audience today before we go?
Well, I'm a very quote person. I will probably use at least 5 quotes per session. I don't know if my clients get annoyed with it, but I think it's okay. I found a quote recently that said, being human is not about feeling happy. It's about feeling everything. And so I think that's what I try to remind people of, is feelings and emotions are part of the human experience, and they're there for a reason. And they are also temporary. You will survive them. And just an acceptance, as the DBT clinician in me, that my acceptance is my personal favorite skill. So just allowing them in your life, they will come, they will go, you will survive.
I will often, it depends on the relationship you have with your client, right? There's some clients where I'm like, is your goal to only always have the feel good emotions? Like, is that what you're working toward? Because I'm sorry to say that's probably not going to happen, right? Like, if we're always striving for, happiness and the silver lining and the excitement, we're going to be disappointed every time, because that's not the reality of the human experience. And yet I understand that society encourages that. Society says, and no one taught you how to deal with the uncomfortable emotions, and society often, or your family or whoever your caregivers were, probably pushed those uncomfortable emotions away or made you feel bad for having them. So it makes sense that it's challenging for you.
Yep, definitely.
Thank you. I love that quote. That's such a good one. Is there anywhere that our audience can find you, to follow you, or get services from you?
I am on TikTok Therapist. Embarrassingly, I don't remember my name. I think it's Chelsey_Nicole or Chelsey LISW-S. I think that's, I don't pay attention to that.
I have
But
so
yes.
many people that ask me, like, what are your favorite, people that you follow, or, other mental health creators? And I'm like, I know them and I'm very familiar with them, but I don't know their names.
Yeah. I was like, let me help you out. And I'm like, no, I don't know it either. I'm sorry. If you remember and you want to send it over, we'll include it in the show notes. People can follow you there.
Yeah.
Awesome. Well, thank you, Chelsey. We appreciate you being here. You're welcome back anytime if you'd ever like to come back as a repeat guest. We have repeat guests often, so just let us know if you're interested.
Thanks.
Yeah, and then to our audience, make sure you like, subscribe, hit the little notification button so you get notified when our next episode comes out. Next time in a couple weeks, we are going to have Christine back. I think this is her third time coming back now, actually. And we're going to talk more about a little deeper dive into what mental health hospitalization looks like and what that experience might look like for the consumer. So as always, thank you, everyone. Have a wonderful week and take care. Bye.
Take care, everyone. Bye.